Okay, so let's now talk about acute respiratory distress syndrome, or ARDS. What ARDS is acute and diffuse lung injury that leads to respiratory failure. In your textbooks, you can look at figure 15.16, and you've got a picture of that. So the patho, kind of complicated. I like to take things and just get rid of all the extra stuff and get it to the nitty gritty. What we have happen is a severe inflammatory response. That response leads to alveolar damage. We have pulmonary edema. We get infiltrates. And the classic sign is hypoxemia that does not respond to oxygen therapy. So we'll look at their O2 sat. We would like that to be 95 or higher, and it's less than 95. My patient's showing some increased work of breathing, shows me that they're in distress. Turn their oxygen up. They don't get any better. I get a gas. I look at my PaO2 or my my PaO2. 80 to 100 is normal, and I've got a PaO2 of 70. So I turn their oxygen up. I wait 30 minutes. I redraw gas. My next PaO2, same or worse. It's not getting any better. That is what it means by does not respond to oxygen therapy. We increase their oxygen, and it does not work. Lastly, the lungs lose compliance. And your lungs have compliance, which is talking about how soft or how stiff your lungs are. So if you think of like a kitchen sponge and you get it wet and you can squeeze it and it's nice and soft, so that's a normal lung. But if you were to use that kitchen sponge and decided to paint with it, decided to use it to apply some polyurethane or something like that, once that sponge dries, it gets really stiff, and now you can't compress it anymore. That's what happens in ARDS. Your lungs get stiff, and we lose that compliance, which further impacts their ability to have gas exchange. So let's talk about risk factors and prevention. So for our adults, sepsis is probably the number one risk factor and cause of why people go into ARDS, followed by pulmonary infections. I don't know why your book doesn't say pneumonia, but it didn't. And usually it's pneumonia that led to sepsis is what we see. Aspiration will do it. Inhalation injuries, trauma. There's a few others listed. I just kind of picked the big ones, the things that we tend to see a lot. And then the interesting one is multiple blood transfusions. So this is patients who've required multiple blood transfusions that can get into respiratory failure, specifically related to the blood transfusion. And I have actually seen this a couple of times. It's pretty rare, but it can happen. In children, the cause is pneumonia, aspiration, major trauma, near drowning, and systemic infections. So really prevention is, let's raise the head of the bed. If they are at risk for aspiration, let's treat the problem. If they're septic, let's treat it. If they have pneumonia, let's treat it and begin that treatment promptly. If they're a burn victim, so think about that as you look at burn content. And we suspect an inhalation injury, so we need to really treat for that. Our trauma patients, very much at risk. I've seen trauma patients who survived their trauma and whatever was broken in their arms and legs to have severe ARDS and end up on ventilators for a long time. And then we just, for things like blood transfusions, just need to be aware that it's there. So let's think about and talk about our clinical manifestations. Okay, so clinical manifestations. The first thing you may see is actually restlessness and agitation. Confusion, changes in the LOC. When I don't have enough gas exchange, that affects all of my body, and certainly the brain is very susceptible and has changes early if we have low levels of oxygenation. Now, certainly we're going to see respiratory problems. Dyspnea, increased work of breathing. So when I think of this, I think of all of those things that you learned in pediatrics about nasal flaring, retractions, grunting, all of that. So those are certainly signs in children, and when we see those in adults, then I get very concerned because those are signs and symptoms in children, and my adult population should be doing that. They'll be tachypnic because they don't have enough oxygen out in their cells, so they will increase their respiratory rate to try to breathe more. They have that hypoxemia that does not respond to oxygen. We're going to lose lung compliance. They're going to have an increase in peak pressure or P peak, and I'm going to talk about that when I do an entire presentation on mechanical ventilation. They're going to have tachycardia. The body realizes that I don't have enough perfusion here. And so it doesn't know if this is a pumping issue in my heart, a breathing issue, or a vascular issue. So it says heart, pump faster, lungs, breathe deeper, breathe faster. Blood vessels constrict. All it knows is I don't have enough perfusion, not getting enough oxygenation. They're going to have crackles and rhonchi. Now, their initial chest x-rays will be normal, but they do later on develop patchy infiltrates, and they get opaque, and it's called whiteout. And that happens 24 to 48 hours after they've developed ARDS. So if you're seeing whiteout, and it may look like, sometimes it looks like there's only one lung, they've been in ARDS for a couple of days. So this increased P peak, if they're intubated, it's the only time you can see that, might be the first indication. If we did an ABG, we would see the hypoxemia, but I will tell you all, we just don't draw ABGs very often. We just look at O2 sat and the other assessment findings we have on our patients. All right, in your notes you do have collaboration, and these are all the people that we may see. Certainly our best friends are our respiratory therapists who need to come and do treatments, and we need to really work with that interprofessional team. We'll have a healthcare provider. We could have a pulmonologist. We're going to get x-rays. We need lab diagnostics. If they've been intubated, we may need speech. We can need PT, OT, all of those sorts of things. So I've made a little list you can add to that. So what diagnostic test are we going to look at? So we may do those ABGs. We may not. I think it's fine as a nurse to say, hey, healthcare provider, I'm concerned about my patient. We're having some breathing difficulties. Would you like to do an ABG? They may or may not. We're going to look at a CBC and a BNP because I need to make sure that what the problem is. Because remember that CBC is going to tell me what their white count is, so that can help me identify whether this is something like a pneumonia. And also I'm going to look at that hemoglobin. If that's low, that could be causing the problem, which means I just need to give them some blood. I need to look at a basic metabolic panel and make sure that I have normal electrolytes. Hypokalemia can lead to respiratory depression, so that could be bad. I need to get my blood cultures and my sputum cultures. I may need an x-ray, could do a CT scan as well. All right, so let's talk about pharmacology. Here's the deal with ARDS. There's really no standard treatment. We will give them oxygen and give them mechanical ventilation and give them PEEP, all of which I will discuss in the next recording. And that's kind of it. We can use corticosteroids to help with inflammation. I can tell you I don't see that a lot, but you can use that. We certainly are going to give bronchodilators to open the airways. We need to do fluid and electrolytes. We need to provide comfort and sedation. We need to do psychosocial support for them, have a therapeutic environment. We're going to use prone positioning. So yes, prone positioning, put them on their abdomen. So a non-intubated patient can turn themselves prone, and an intubated patient, one therapy we will use is to turn them prone. The problem with proning for a non-intubated patient is you actually need to stay prone for many, many, many hours, and it's difficult for people to do that. But even if they can turn prone and lay there for a couple of hours and then turn back, that will be somewhat effective. So be sure and look in your outlines. You've got some specifics here. You've got some specifics on comfort and sedation. We need specific orders for this. We do want to start with pain control first. So let's treat their pain, because that may be all we need to do. Because just because my patient's intubated on a ventilator does not mean I have to sedate them. So we will start with pain. I will tell you we see a lot of fentanyl drips on these intubated patients. We need to titrate our sedation for a specific goal. They use the RASS score, which is the Richardson Agitation and Sedation Score, and we will be given specific parameters. Typically, that is -2 to 0, and the specifics of what that means is in your comfort fast facts. 0, I like to say, is me laying in my bed in the morning and I'm awake, but I haven't opened my eyes and I don't want to get out of bed yet. But I know everything that's going on, but I just want to stay in bed. That's how I think of 0. -2 is somebody who wakes up, follows simple commands, and remains awake about 10 seconds, and then they go back to sleep. But they do wake up, they do follow commands. And we do have problems if we have patients over sedated, and we have problems if patients are under sedated. If you're over sedated, then you're not waking up, you're not following commands, you're going to be on a ventilator longer, and you are put at higher risk to develop things like ventilator-associated pneumonia, or what's called VAP, VAP. If you're under sedated, then you may be anxious, you may be trying to get out of bed, you might try to pull your tube out, you're a danger to yourself and to others. So we need optimal sedation, which means you can wake up, easily follow commands, and remain calm. So let's talk about our lifespan considerations. So for children, we have to treat the underlying cause. We don't do proning, we don't do corticosteroids. Intubation is used if there's no response to anything else or we have worsening ARDS. So we are much more likely to intubate proactively sometimes an adult population. On children, we really want to wait and not do that till we absolutely have to do that. And then they do what's called permissive hypercapnia, which is to allow that PaCO2 to elevate just a little bit. And they have specific parameters for that. So for our pregnant women, we need to treat the underlying cause. We do have to frequently monitor that fetus. And we do think about delivering the baby if the oxygenation is severely impaired and if that baby is at least 20 to 24 weeks, which is viable. So for our older adults, they are more at risk for developing ARDS, especially if they're 70 or older. They're more likely to die from multisystem organ failure or MODS and have other complications like developing sepsis. They also have cardiovascular disease, diabetes, renal failure, and it makes it much more complicated. All right, as I glance at your outline, there are some good notes for you about proning, the things that are important, why we do prone. It does improve gas exchange and recruit those alveoli, and it requires a team to do this. And the biggest complication is that we can dislodge our tubes and lines, which would be losing our ET tube and also having a central line fall out. So what are we going to do? So we're going to provide respiratory support. We're going to provide oxygen and maintain an O2 sat of at least 92%. That comes out of your book. I will tell you I would prefer to see an O2 sat of 95% because an O2 sat of 90 can mean that your PaO2 is 60. Non-invasive pressure ventilation, so CPAP, is used to improve oxygenation and maintain airway patencies for patients who are breathing spontaneously. Think of CPAP, this is what people wear at night who have sleep apnea. BiPAP is positive pressure during both inhalation and expiration for spontaneously breathing patients. So we could do BiPAP. And if they're going to be needing BiPAP, they're going to be in an ICU. We're not going to do BiPAP on the floor. So they have a mask that's tight fitting that has pressure both for inspiratory, expiratory, which makes it difficult for them to communicate, makes it difficult for them to get nutrition, even just getting a drink of water, because you have to loosen that mask, put a straw in there, you've lost the pressure, and just that is enough to see O2 sats actually fall. You can get skin breakdown, and it's a comfort issue, and some patients just do not tolerate BiPAP, but it is what we can do. So if putting them on like a non-rebreather mask, as high as we can turn that up to get them about 90% oxygen, isn't working, then we will look at two things like BiPAP. If BiPAP doesn't work, then our next step would be to intubate them. So you do need to think about your nursing interventions for somebody with respiratory support. You know, if they're starting out and they're only on 2 liters oxygen, well, let's turn up their oxygen and see how that helps them. Do those measures to decrease their O2, increase their supply, decrease their demand, and see how we do for them. See how they do for us, how our interventions work for them. That did not sound quite correct. Okay, that is the end for this section. Come back for the presentation on mechanical ventilation.